Welcome everybody to Beta Blockers Made Easy by Nurse Muse, and please, as always, go to www.nursemuse.com and sign up. It's a fabulous website. It helps you write your care plans, and it has a ton of great resources on there to help you be successful in nursing school. So let's jump into beta blockers. So beta blockers are also known as beta adrenergic blocking agents, and we give these medications to reduce blood pressure. So when we talk about beta blockers, what we're doing is blocking the effects of the hormones epinephrine and norepinephrine. Epinephrine is also known as adrenaline. So many beta blockers you'll find end in OLOL. Okay, so propranolol, it's a great example. So anytime you see a medication with the ending OLOL, beta blockers should come to your mind. So they block the beta receptors in the body. They're also called catecholamines, such as epinephrine and norepinephrine. Okay, epinephrine and norepinephrine are catecholamines. So their whole job is to block the sympathetic nervous system. Now, I'm sure you can recall from your A&P classes that the sympathetic nervous system riles up your body system. Okay, this is a fight or flight. This is you're out in the wilderness and you see a bear and the bear starts chasing you. You're either going to stand there and fight or you're going to run away and flight. So if we're going to run away from a bear, we really need to get the blood pumping in our body. So when the sympathetic nervous system is activated, it's going to increase our heart rate and increase our blood pressure, which is going to increase our cardiac output to get that blood pumping as fast as it can to all of the extremities so we can run really fast. It's going to increase the oxygen consumption of the heart because our heart is beating really, really fast. And those cardiac myocytes, they're going to be contracting really, really hard to get that blood pumping out as fast as it can. We would like to be able to breathe while we're running, so it's going to cause bronchodilation. And actually, our blood sugar is going to increase from the liver because we have to have energy when we're running fast. So this is great if you're in the fight or flight mode and you're deciding to run away from something. But for patients, especially patients who have cardiac issues, we need to stop this system because we need to decrease the workload of their heart. So this is why we give beta blockers. So what is the goal with hypertension? The goal is to reduce the workload of the heart, and we want to block those receptors that we just talked about so the heart does not work so hard. So beta adrenergic blockers, the BAB, OLOL. So we give it, as we talked about, for hypertension. We can give it also for dysrhythmias and angina because we're increasing the oxygen to the heart muscle, compensated heart failure, glaucoma, anxiety, and sometimes tremors. So again, normally when we're out in the wilderness and our sympathetic nervous system kicks in, we want norepinephrine and epinephrine to hit these receptors because we need to start running and start running fast. But if we prevent the sympathetic nervous system of starting, we're going to reduce our heart rate, reduce cardiac contractility, and have a relaxation rate, which decreases the myocardial oxygen demand. So when we give beta adrenergic blocking agents, remember those are beta blockers. So what does beta 1 do? So it's important to know that we have three, but we're going to talk about two types of beta receptors. We have beta 1 receptors and beta 2 receptors. So anytime we talk about beta 1 receptors, we're talking about receptors in the heart. We just talked about this, but norepinephrine and epinephrine activate the beta 1 receptor in the heart. So again, we're activating it. We're going to pump that heart really, really fast, really, really hard. We're going to increase our bronchioles so we can run fast and make sure the blood goes down to our legs. So beta 1 and beta 2. Beta 1 is in the heart, and beta 2 are found in many different tissues. So the most important one that I want you to remember with beta blockers is that it affects the smooth muscles, especially that of the respiratory system. So when we stimulate those beta 2 receptors, remember we're being chased by the bear, what's going to happen is our smooth muscles are going to relax so that we can get more blood down to our extremities so we can run fast and so we can get more air in and out of our lungs. So when beta 2 is stimulated, the result is going to be vasodilation. We need to be able to breathe a lot because we're running fast. So the way to remember beta 1 and beta 2 receptors is that we have one heart and two lungs. So when we talk about beta 1 receptors, think about the heart. And when we talk about beta 2 receptors, think about the lungs. So in the beta blockers, we actually have two more categories, selective and non-selective. So selective, cardioselective, they're also known as cardioselective because they're selectively affecting the myocardium, the heart. The selective beta blockers are very selective, so they only go after the beta 1 receptors. Okay, then we have the non-selective beta blockers. They're not selective, so they affect both beta 1 and beta 2 receptors. So beta 1 receptors, beta 2 receptors, then we have selective, non-selective. So again, we have one heart, two lungs. So beta 1, I want you to remember, is found in the heart. Now it's also found in the kidneys, and the kidneys is where renin is released. And we haven't gotten to the RAS system, but we're going to. So when the RAS system activates, it's going to produce angiotensin II, and we're going to learn all about how these blood pressure medications affect the RAS system. Beta 2 receptors, remember they're found in the lungs. They're also found in the GI system and the ciliary muscle in the eye, which is why these are really good for glaucoma patients. And then beta 3 receptors, they're found in the fatty tissues, but we're not going to worry about that for this presentation. So just remember, if we give selective beta blockers, how are they going to work? They're going to affect the cardiac conduction of the heart. So it's great at treating tachycardia because remember, if we block those receptors, we are going to slow their heart rate. Now, one thing you as a nurse need to be aware of is we need to make sure we don't slow their heart rate too much. So make sure that you're always assessing heart rate with patients on beta blockers. Also, beta blockers have been shown in the literature to cause second or third degree heart block. So we always need to be monitoring for that. And then, of course, the goal is to decrease the contraction strength of the heart. So we're trying to allow the heart to get more oxygen. But by doing that, we don't want to decrease the contraction of the heart so much that we put them into heart failure. So we need to be assessing those signs and symptoms of heart failure, which would be edema in the periphery, wet lung sounds, rales, rhonchi, swelling of the belly, having shortness of breath. So remember, it's going to decrease our heart rate. That's what we want, but we don't want to decrease it too much. And we want to decrease the strength of the contraction of the heart because we're letting the heart rest in between beats to get more oxygen, but we don't want to make that beating heart too weak. So more mechanisms of action for selective beta blockers. Remember, these are selective, so they only hit beta 1 receptors. They're going to hit the kidneys, and we're going to stop that RAS system from being started. So when we don't allow RAS to start, we're going to decrease our blood pressure because, as we know, the heart and kidneys are BFFs, right? They're best friends. And when we affect the heart, we're also affecting the kidneys. And when we affect the kidneys, we're also going to affect the heart. So just know that the RAS system cannot be started, which in turn, we're going to learn more about the RAS, but in turn is going to lower the blood. So then we have non-selective beta blockers, as we just talked about. So they're going to hit the beta 1 and beta 2 receptors. So when we give beta 2 non-selective medications, what it's going to do is decrease intraocular pressure, which is great for our glaucoma patients. The cause of glaucoma is too much pressure behind the eye. So giving a beta 2, you're going to decrease that pressure. Beta 2 receptors can cause bronchoconstriction. Remember that we're hitting the beta 2 receptors in the heart, in the lungs. So when the sympathetic nervous system kicks in, the lungs are going to vasodilate, but we're blocking that. So now we're going to vasoconstrict. We're going to bronchoconstrict. So of course, we don't want to use these medications with asthma or COPD patients who already have a hard time breathing. Beta 2 non-selectives can also cause hypo and hyperglycemia, so we need to teach our diabetic patients to monitor their blood glucose even further. And it's really important to know that if you're on a beta blocker, the whole goal is to decrease your heart rate. So diabetic patients might seem to be able to feel when their heart rate starts increasing when they have hypoglycemia. So we need to educate our diabetic patients to check their glucose even more closely on a beta blocker, because they might not get that sign and symptom of having a higher heart rate. It's going to cause peripheral vasoconstriction. Remember, when they're stimulated, we're being chased by the bear, everything opens, so the blood can flow really fast down to our extremities. But this is going to cause peripheral constriction. So we need to educate our patients that they can experience ED, erectile dysfunction. You might assess cold hands and cold feet. So thinking about that further, we probably don't want to give patients who have peripheral vascular disease beta blockers, because it's just going to constrict the peripheral extremities more than is already being constricted with the PVD. So of course we know that beta blockers are hitting the kidney receptors. So we really need to make sure that we are assessing kidney function. So we're looking at the BUN, the creatinine, and any protein. So the literature does show that the renal blood flow is going to be decreased, as well as the filtration rate by the kidneys, because we're decreasing the blood that's getting there. So we really need to assess our kidney function and our respiratory function. So by now you should know that beta blockers we're never going to give with asthma or COPD patients. It's going to constrict our bronchioles. So of course we need to be assessing for signs and symptoms of the bronchioles being constricted. Are they getting signs and symptoms of heart failure? Are they not being able to cough up all those secretions that are in the lungs like they used to? So we're always listening for breath sounds when our patients are on blockers. Because our bronchioles are going to constrict, so we do not give beta blockers for asthma and COPD. So again, you're always going to assess. You're going to think beta blocker. We're going to think about respiratory system, renal system, and then diabetes. We need to think about that hyper and hypoglycemia. So we're going to assess for our lung sounds. We're going to be checking our lab values for kidneys. We as a nurse need to be aware that we are decreasing their heart rate, but we don't want it to get too low. So we need to be assessing for bradycardia. And like I mentioned earlier, it can cause second and third degree heart blocks. So we need to be assessing for that. We talked about this, but we don't want to exacerbate any heart failure. So we're going to be looking for those heart failure signs and symptoms: lung sounds, weight gain, edema, really looking at their INO. Beta blockers, you can't just stop. So if the patient is on beta blockers for a long time, they need to speak with their provider of how they're going to get off of it if they need to get off. So usually we taper about 2 weeks. If you just stop, you might get rebound hypertension. You might get some angina. because of that ischemia happening in the heart muscle. We want to think about asthma and COPD. These should not be on beta blockers. We need to think about blood glucose. Remember, the non-selective medications can cause hypo and hyper. And we need to make sure that our diabetic patients know that it can mask the signs and symptoms of hypoglycemia, so to check their glucose even further. We want it to lower the blood pressure, but of course we don't want our blood pressure to plummet. So we're going to be monitoring the blood pressure. These patients are at risk for orthostatic hypotension. So part of our teaching is for them to get out of bed slowly and carefully, or change positions slowly or carefully, because they might become dizzy and it's a risk for fall. We talked about circulation impairment due to that peripheral vasoconstriction. So educate the male patients about possibility of ED. Think about those cold hands and cold feet. And we're not going to give this to a patient who already has cold hands and cold feet because of their PVD. And then you can overdose from beta blockers. You can have signs and symptoms if you've given too much of a beta blocker. So this would be just an exacerbation of what it's supposed to do. So the heart rate is too slow. We have severe hypotension. We're very lethargic. And of course, the heart block, second and third degree heart block. So when you're giving a beta blocker, just think that everything kind of slows down. So we have a low blood pressure. Our gut motility is probably going to slow down, so we need to monitor for constipation. We're going to have slow blood flow due to that peripheral vasoconstriction, so our hands and feet are going to be cold. We're going to be slow moving. It can cause lethargy. So we might have some weight gain. Patients might feel a little fatigued. Now, of course, if they're, you can't wake them up and you see a huge change in the amount of fatigue that the patient has, this might be an overdose, so we would stop the medication and call the provider. And then, of course, the hyperglycemia, that's really important. You need to tell the patients to really monitor their blood glucose so that they don't go into hyper or hypo without it. So I hope this review was helpful, and I will see you in the next review. Again, if you have any questions, you can email me, cprado@aol.com. You can text me at 702-493-3420. And of course, please sign up for Nurse Muse. It's a great tool for learning how to write care plans, and it has a ton of resources on there for you to be successful.